All right, so before we get started, just there are if you know anything about Zoom, you can find the Q&A spot. So if you have any questions as it goes along, please answer the question at the end. We'll go through the questions and answer as many as we can. And I've put Dr. Daly in charge of Q&A. Steph, our nurse practitioner, may also join at some point. She's done a lot of the legwork on vaccines, so we just want to make sure she's available. She can give us her perspective and answer those questions too. So let's get started. So why am I doing this? Well, we get a lot of questions every day about the vaccine, about testing, and just really important for us to get started and just let you know what our perspective is and where we stand as a practice in COVID-19 vaccines and testing. So if I can get this. So first, most of you, I've seen the list, are members of the practice, but there may be people on the call or the webinar that are not. So I just want to introduce you to our practice, who we are, what we do. I'll just spend a couple minutes here. I'm an internal medicine doctor, as is Dr. Daly, as well as our other partner, Dr. Dan. And we have a nurse practitioner and a couple of support staff. We are not virologists or specialists in virology. We are not public health experts. We are frontline doctors, primary care physicians who are caring for people, some of them who have had COVID over the past 10 months. Our goal has always been to try and protect our patients from getting COVID, and we don't want them to have it, and we certainly don't want them to die from it, and one of our patients did. So we have been sending out emails. We have got a blog. The goal is to educate you all along. And a lot of you, I know, get our letters. Some of what we talk about today, if you've read them, will be duplicative, and some of the information hopefully will be new to you. So we are a small volume practice. People pay an annual fee to become a member. Each of us will peak out at 300 patients per practitioner, which is, what is that, Dr. Daly? You had 5,000 patients at DMG?
Yeah, Northwestern 5,000, yeah.
Yeah, so 300 is a manageable number. So core services are part of the membership. If you want to learn more, website's right there. I've also highlighted our blog, so you could look back and read any of the blogs, any of the emails that we have posted. So that's who we are. If you're interested, if you're not a member, we're happy to answer calls about our practice. So I want to start with vaccines, and then we'll talk about testing. We're going to talk about the science of the vaccines and our recommendations. So, brief review of science. Meg and I nerd out on this stuff, and we'll try and get you a little bit educated on the virus. So the Moderna vaccine and the Pfizer vaccine are both what we call RNA vaccines. A lot of us know what DNA is. It's our genetic code. RNA is just a segment of DNA, basically half of it. It comes out of the nucleus into the cell, and it's used to make a protein. RNA is used to make protein. So that comes from the genetic code. On the surface of the virus, the SARS-CoV-2 virus, there's a spike protein. That protein, which a lot of you may have heard of, is critical for the entry of the virus genetic material into the cell. That RNA bacteria codes the spike protein, which then the vaccine will then, that spike protein will trigger our immune system to fight against the virus if we happen to get exposed to it. And here you see these little antibodies in cartoon form attaching to the virus, and then our immune system will kill it before it has a chance to kill us. So RNA vaccine, we actually get injected with that RNA, and it uses the engine of our cells to make multiple multiple copies of the spike protein to trigger our immune system. So the idea of the vaccine is that it actually pretends like you got infected, and then our immune system is primed at the pump to protect us. There are other vaccines in development that have different technologies. It just so happens that Pfizer and Moderna, the first two, have this RNA vaccine model. How does this vaccine work? You know, how did they study it? Does it work? So at the top, you've got thousands, 30 to 40,000 for each of the vaccines people that they recruited into the study. Half of them got the vaccine, half of them didn't. They were told to go live their lives for a couple months, and just, I don't know the exact numbers, but there were 100 cases of COVID at the end of 2 months. 95 of them were in patients who didn't get the vaccine, and 5 cases were in people who did. So that's why we say it's 95% effective. What's important to note about the way they studied the people was initially in the phase 1, initially as these companies were developing the vaccine, to check to see whether it worked or not, they looked for the antibody response. You may have remembered this from back in the summer. The big news was it created antibodies. For the vaccine study that we are getting results of in real time over the past couple of weeks, they weren't looking for the antibody response. They were actually looking to see if people got disease. So it may be that even more people mounted an immune response, but we're not sure because we don't have the antibodies to prove it. All we know is that it prevented symptomatic disease in 95% of patients who received the vaccine. So does it actually prevent all disease? Many of you know that there are asymptomatic people who have COVID-19. They walk around, they have it, they never get symptoms, but they're actually able to spread it. So the question that remains is, in some people in this group who got the vaccine may have gotten asymptomatic COVID-19, and could they actually spread that to other people? We don't know that yet. So there's still some questions that we need to learn, and maybe in further research, they can look at the antibodies in these people, but the FDA wanted it to be disease prevention. They wanted that to be the goal, and so that's what Moderna and Pfizer studied. So going back, there's 2 things going forward as we look at this vaccine, and does it work, and are there side effects? So the efficacy, which I just talked about, it's 95% effective, but I don't think that in the end, it's going to actually be 95%. Why? One reason is in the study, it was 100% effective in people over the age of 75. Now, nothing is 100%. That's just an impossible number. So it is likely that as more people get the vaccine, we're going to see that 100% number drop. I don't know to what number, but it will drop, because we know from vaccine efficacy that actually as we get older, vaccines aren't actually as effective, which is why the older adult flu vaccine is actually a bigger dose. So we'll keep an eye on the efficacy numbers as things go forward. The other issue to look at is people just went about their normal business after they got the vaccine. Now, a lot of people may have just gone home and hibernated for a couple months, so they didn't actually get exposed to the virus to know whether it would have protected them. So that's another thing to keep in mind as we look at the efficacy numbers. Now, what about side effects? So the good news is that the side effects of the vaccine are tolerable. Many of you have had the shingles vaccine, and after the shingles vaccine, people can get punky sick for a day and a half. And in one case, my patients was a lot longer than that. But most of the patients get symptomatic, or a lot of patients do, for about a day. So we think that from a symptom perspective, based on the reports from Moderna and Pfizer, that maybe the Pfizer vaccine has fewer side effects, but most of them are pretty, I would think, compared to having full-on COVID, I think a lot of us would accept some of these side effects. We don't think that going down the road with regard to side effects or safety with regard to the vaccine, that we're going to have any new ones pop up, because 20 to 30,000 people actually got the vaccine. And so if there were more significant side effects, it likely would have shown up in that population of folks. So we're pretty confident that over the next 2, 6, 12 months, we're not going to see any significant number of side effects pop up. The other thing I will say, though, is that these companies have applied for emergency use authorization. And for EUA, the FDA said we only need 2 months of safety data. We only need 2 months. They had to decide this. They've never done an EUA for a vaccine before. So they decided, hey, let's just look at 2 months worth of safety data. If these companies want full approval, they need to provide 6 months. So let's see over the next 4 months. I don't think they're going to apply for full approval. The EUA process for most FDA-approved drugs or tests, companies can keep that emergency use until the emergency is over, or until something causes the EUA to be taken away. So it's likely that these will be, in force and no relook by the FDA until after the emergency is over, which hopefully will be at the end of the year when enough people have gotten the vaccine. So I want to sort of talk about herd immunity, because I think herd immunity gives us this is what we're going after. We're aiming for herd immunity, where if you aren't vaccinated, the people around you are going to protect you. This is what happens if we don't have a vaccine, and what we're seeing in certain communities. One person is sick, and then it spreads to a number of people around them, and eventually, or hopefully not, then everybody gets sick, and a number of people will pass away. So that's not what we want, and that's why these vaccines have been developed. So we vaccinate people, but let's say we don't vaccinate everybody. The yellow are the people who are vaccinated and safe. The blue are people who either didn't take the vaccine because they chose not to, or they did not successfully mount an immune response to the vaccine. And we see that. We see that in people who get hepatitis vaccine sometimes. We see it in people who get, I think the shingles vaccine, but I know for a fact that there are people who don't mount an immune response to the hepatitis. Some people don't mount an immune response to the hepatitis B vaccine. That's going to happen with COVID-19 vaccine. People are going to get vaccinated, but they're not going to be protected. So if you are a vulnerable person and not everybody gets the vaccine, then it's just going to spread and you're going to be vulnerable. So in the ideal case, enough people get vaccinated, and then it protects the person who's vulnerable. That's what herd immunity is. It protects the people who are vulnerable with a shield of vaccinated people around them. So if this person happens to get sick, they won't infect this person because there's a shield of people around. So that's what herd immunity is. It's not, as you've heard, enough people getting sick. And if everybody gets exposed and 60% of the population gets sick and gets immune from that, you still get herd immunity, but a lot of people are going to die in that situation. So we never conceive of herd immunity as enough people getting sick and getting immune from illness. So that's the idea of herd immunity. And the goal for COVID-19 is that we want about 60% of the population to either be immune from an illness or immune from the vaccine. If we don't get enough, we could be in this situation. So that's the goal from a public health perspective, is to get enough people vaccinated, not just for your own sake, not just for you to protect you, but actually to protect you in case you don't mount an immune response. So when is the vaccine coming out? Well, we already know that Pfizer's been approved. It's already been released. And Meg, when are you getting yours?
I got the link to sign up, so probably within the next week.
Well, go right now and sign yourself up.
I had to do this first, and then I'll sign up.
Okay, thank you for being here. So Pfizer released 20 million vaccines. That was expected by the end of December that they were going to release, I think, 5 times that amount. And they've guaranteed another 50 million by the end of December. So it just gives you an idea. They are starting to come out. And what happened today, Meg? I haven't been in the news.
Oh, that they gave EUA to the Moderna vaccine.
All right. So you've got now 2 vaccines that are available and that are going to start being released to states for distribution. So Dr. Fauci, who a lot of us trust, said that based on what he sees in the future with regard to these 2 vaccines, plus the AstraZeneca vaccine, the Oxford one, and the Johnson & Johnson vaccine, between all of those 4, which he anticipates approval as we get through the first quarter of 2021, that everybody would be able to walk into a pharmacy and ask for a vaccine by the beginning of April. Now that's assuming everything goes smoothly and everything goes as it's planned. But that's a hopeful, it's a more bullish thought than I've predicted. I was thinking more towards the end of the summer, but let's hope it's correct, and anybody who's on this call and their family and friends will all be able to get a vaccine by then. So who gets it? Who's allowed to get it? Who's eligible to get it? Well, the vaccine's being distributed to states, and the states decide how they're going to distribute the vaccine. They get recommendations from the FDA, from the, what's it called? The ACIP, the Council for Advisory Council for Immunization Practices, the ACIP. So they provide recommendations to the FDA on who gets the vaccine when, but when it comes to the states, they can kind of pretty much do whatever they want. So that's why you might hear of friends in Florida who are getting the vaccine. But up here, it's just the doctors and healthcare workers. So here's the order that's been proposed for the state of Illinois, where most of you are. And I know some of you in Florida, and you might actually have earlier access to it than we do up here. But most of you are in Illinois. There are 760,000 people in the first batch of, it's called phase 1A. And that's healthcare workers and long-term care facility residents. 760,000. The first batch of Pfizer vaccine was 110,000. The state has said that this is going to be, until we get the majority of this done, we're not moving to the other phases. We're going to get phase 1A done. So we need to get a lot more vaccine to get this done. We don't know when that's going to come. As I said, 50 million by the end of January. We've got Moderna coming in. I think they said 150 million doses worldwide by the end of January. So there's hope, here in Illinois, that we'll get through the doctors and long-term care facility residents before we move into the next phases of phase 1. The way they define the phases, phase 1, 2, 3, and 4 here in Illinois, phase 1 is when the vaccine is in short supply. So we're really prioritizing the small number to people who are at the highest risk. So supply comes to Northwestern, and I suspect that the first people that they vaccinated were the emergency room doctors, intensive care unit doctors, intensive care unit nurses and staff, and other people who have direct access to potentially COVID positive patients. So now they're moving to, lower level people like Dr. Daly and me. So that's the 1A. So I'm sorry, phase 1 is when the vaccine is in very short supply. So let's say we move into the end of January and February, and we've got another vaccine that can be released. We've got more vaccine available. Then they'll move into phase 2. But within phase 1A, B, and C, there are a lot of people. There are a lot of people. And Illinois hasn't finalized who goes into what category. We're going to focus in on 1A, and we're going to figure out the rest later. They're figuring it out now, but they haven't really confirmed it and told us who those people are going to be. So this is a suspicious or suspected thought about who, and it's coming directly from the State of Illinois website. So frontline workers would be like people who work in exposure to people, like if you're in a restaurant worker or a delivery person, people who are face-to-face with people and work with people who could have COVID-19. I don't know. I mean, it seems to me that these would be almost in parallel, but over age 65, high-risk individuals, maybe teachers. Teachers might be a frontline worker. It's not clear. It's not clear who's in what category yet, particularly in the state of Illinois. And the essential workers are sort of like factory workers, as opposed to people who are face-to-face with potentially people who have COVID-19. And then as we move into phase 3, when the vaccine's fully available, it'll be my adult children who will get the vaccine then. I certainly would like them to be way up here, but they're probably near the end of the line. I hope, my son, when he goes off to, like both my sons, when they go off to college in August, they will have gotten the vaccine by then. And phase 4 is really just catch up, just making sure that everybody who has access may have missed it, we can get them situated. So what about us? Are we going to have the vaccine? Are you going to distribute it? When can we get it? Do we have to get in line? All those questions come our way. If we go all the way to phase 4, they've said that in phase 4, all doctors' offices will have access to give vaccines to their patients. So phase 4 is a long way from now. We're not waiting until phase 4 in order to get access to the vaccine. So we have signed up. We were on the list early to become a distribution center for vaccines. They know how many patients we have. They know what freezers we have. They have all that information. And so what that means is at some point we can get a direct shipment from likely Moderna, but perhaps from Pfizer. We would just have to move real fast with Pfizer because we don't have a deep freezer here. But we're on the list and we're hoping that we'll get vaccines distributed to us. We're just, watching the clock and hoping that they call our number to be able to distribute it to you. Our recommendation, though, is if someone knocks on your door and says, it wouldn't be anybody, but if a responsible person knocks on your door and says, we have the vaccine, I would say, yeah, take it. I suspect that these are going to be distributed through CVS and Walgreens and pharmacies. So when they come into those pharmacies, the pharmacies are finished vaccinating the long-term care facility patients. At that point, they may say, if you're over age 65, if you have a chronic illness, if you're a frontline worker, the vaccine's available to you. I don't know if that's the case, but that's what I suspect. So if you have that access, don't wait for us to tell you that we have it. Once it becomes available, if you can get it, take it. And I want to reemphasize that all of the clinicians here at Harper Health, as Dr. Daly just said, if our number comes up, we're getting the vaccine, and we will tell you what our experience was, the good and the bad, depending on the side effects. So,
do you want to go through some of the questions?
Yeah, why don't you go through some of the questions on the vaccine
before we go into the testing?
Yeah.
People are wondering if there are other lists to put our name on, their name on. get access to the vaccine if not through our office?
There is no list. There's no list that you can sign up for. You can't Google like COVID vaccine list. There isn't. And part of that is because the state hasn't gone beyond 1A in their public communication. A friend of mine, their mother got it down in Florida. I don't know how she was identified as being someone who could get it, but she got it. So my suspicion is that, we may be providing a note, a doctor's note that says you have a chronic illness. You can provide your ID that you're over age 65 if we're not distributing it here. Another possibility is that if you have a doctor at a hospital, if you have a specialist from one of those chronic diseases, they may tell their patients, the process of coming to the hospital to get the vaccine. So I wish I had a better answer, but the state of Illinois has not been very clear on how the process after 1A is going to work.
Another question is, prior to getting the vaccine, should we take the supplements that we got from Harper Health? And I can chime in on this. I don't think that the supplements will do anything that helps your immune system be more robust in terms of its immune response to getting the vaccine. I have heard of some people who have taken a Benadryl before getting it, just to prevent any potential rash or something like that. But even that, there's been no official recommendation on pre-treatment with any kind of medication or supplement.
I'll just add that it sounds to me like the side effects to the vaccine are pretty common side effects to vaccines. Maybe a little bit more severe, similar to the shingles vaccine reaction, but from what I've heard, it's definitely something that we can handle.
Next question is, what is our opinion on getting the vaccine if you have food allergies, specifically egg allergies?
So the vaccine, this particular vaccine was not made with eggs. There is I think a Chinese company that's using that technology in a similar way that the flu vaccine is made. So you definitely don't need to worry about egg. It's completely different. My understanding is if you've had a severe allergic reaction to other vaccines, like a true allergic reaction is called anaphylaxis, where your throat closes up and you get difficulty breathing and a rash, that is an indication to not get the vaccine and therefore hope for herd immunity. But other than that, like food allergies or seasonal allergies or anything like that, I have not heard that is a reason to not get the vaccine.
Yeah, I think the difference is because this is an RNA vaccine, it's not grown in a culture medium that contains food. Some of the older more traditional style vaccines were grown in a culture that had egg, and this doesn't have that as part of its manufacturing. So there should be no food component to this vaccine. The next question is there a COVID vaccine that does not alter our DNA?
So this particular vaccine is an RNA vaccine. So the DNA is in your nucleus and the RNA is in what's called the cytoplasm outside the nucleus, but inside the cell. Now, RNA cannot go into the DNA because they're completely different molecules. DNA is Watson and Crick, double-stranded curly Q nucleic acids. RNA is just one string, so it can't get in there. Now there is a theoretical, what if there's what's called a reverse transcriptase enzyme and all this manufactured theories about how this RNA virus could get into your DNA, but the chances of that are very, very, very slim. I mean, it's just a imagination, almost possibility. There is a vaccine that is in development that is a DNA vaccine. So injecting DNA that then gets turned into RNA, that gets turned into a protein. That one a little more bearish on. I'm not sure that that's one that I'm going to put to the top of the list of recommended vaccines, because then you might be concerned about integration of that DNA into your genetic code.
Kind of as a spin-off of that question, someone asked if we have a vaccine preference, the Pfizer versus the Moderna.
I haven't seen the public data on Moderna. I've seen the public data on Pfizer. So my initial impression based on the press release data is that they're equivalent. And if you get the option to get one, it doesn't, to me, it doesn't matter Pfizer versus Moderna. However, it is important that you get the same one twice. Don't do Moderna one and Pfizer the other. You won't get the robust immune response that you need.
How long does the immunity from the vaccine last? Is it going to be a seasonal situation?
So the vaccine was studied for 2 months before they, so we don't know how long the vaccine is going to last. We don't even know if being sick and immune to COVID-19 lasts. And we think it does because we haven't seen in the literature a lot of people who've gotten it twice. My suspicion, if the vaccine works like infection, you're going to get at least a year because that's what we've seen so far.
Somebody typed in, will young adults really go before a 60-year-old who does not have high risk issues?
We don't, like, at least in Illinois, there's just, we have no idea. There's been things published for different states that show different, pathways of who goes before whom. And I just don't know. I don't think that a healthy young adult is going to get it before a 60-year-old. I just don't think that's the case. But I'm sorry, I wish I had a better answer for you.
And someone else wrote, who's falling under the high risk category? Is there a list available? Does Harper Health have a list? We have not started categorizing our patients or making any sort of internal list.
Not yet. And we're sort of trying to tease out from both the Illinois and from the FDA on who fits into what category. I can share a link, or you can go to just Google, Illinois COVID vaccine order, and you'll get the website that I got my information from. And it does mention like cancer patients and heart failure patients, but there are certain illnesses that probably won't get you to the top of the list. Like if you have seasonal allergies, I'm not so sure that's going to get you there, but if you have asthma, it probably will. We wish, from my perspective, I wish that everybody on this call was classified as high risk for the purposes of the vaccine, but had no high risk illnesses in reality. So that's what our hope is that you're all healthy and perfect and wonderful, but sick enough to get the vaccine. More to come on that. Certainly more to come. This is just, this is not the end. This is the beginning of the end.
Is Northwestern Medical Hospital in Chicago making the vaccine mandatory for all the healthcare employees working there, i.e. the people who take your blood, administer your x-rays, et cetera? And I can tell you this, it's not mandatory, it's voluntary.
They make the flu shot every year mandatory, but because this vaccine is only under emergency use, they can't just legally can't tell their employees to get the vaccine. I don't know what percentage will refuse it at this point because we're just getting started.
Is there a study or recommendation of which vaccine should be taken by those older than 65? Is there one better than the other in terms of the way they work?
So again, I haven't seen the raw data from the Moderna study, and we're going to learn more hopefully as things go forward and we get, one 75-year-old person who's gets COVID after the vaccine. So the head-to-head, there's no head-to-head trial yet on which one's better in which situation. And I think the preliminary data that we get from Pfizer and Moderna is just that, it's preliminary because it's going to change as millions of people get these vaccines.
How do you find out the availability or lists in other states?
Good question. I mean, you could go to for example, the Florida public health website, and if you have a home down there and you can find some way to get down there safely, maybe you could get the vaccine sooner down there, but just don't get COVID on your way. That would be my hope. So let's do the testing piece and then we'll come back to the questions, okay?
Okay, there's a ton.
I know.
I could keep going.
Yeah, I know you could. And we'll come back to as many questions. I was just going to add to it on here. So
we can always try to answer the questions and
offline. Yeah, we'll maybe put it into a post after. So testing. This was in an email I sent out, and I just want to there's a lot of anxiety about whether you have COVID or not, and particularly if you've been exposed. And we get a lot of calls from people that, I was exposed. Like I got a call yesterday, family's nanny kind of exposed the family to COVID. And then one of the adult children, she's not being nannied by the nanny, but they hung up the lights together on the Christmas tree. And so she was exposed and she went right away to get a test. That's just not scientifically helpful. That negative test is not useful, and I'll tell you why. So background, there's two basic types of tests to see if you've got COVID-19. One of them is an antigen test, and the other is a PCR test. As we talked about before, this spike protein, that protein is what's called an antigen, which is what triggers the immune response. Anything can be an antigen if it triggers your immune response. So someone gets exposed to COVID, and this, when you take the sample in the nose, hopefully not down the back of your brain, but if you take the sample in your nose, you have to have enough of the virus sample, the virus on that swab, in order to be picked up or detected by the rapid antigen test. The two that are available are BD and Quidel. So the sensitivity or the ability to pick up the virus is not that great, particularly if you're early on in the illness, or if you're later in the illness, where you've basically cleared most of the virus. So antigen testing is ideally for people who are really sick. And when they're really sick, they have a high viral burden, and you're going to be able to pick up that antigen a bit easier with these rapid antigen tests. PCR testing is very different. They take the genetic code, they isolate it, and they make thousands, millions of copies of it, and then they look for the genetic code with the machine. So you don't have to have as much virus present in order to detect yourself, detect the virus inside of you. So this is why the PCR test, or the nucleic acid test, is preferred overall. It's just a better test. It's just going to detect the virus. Always, it's going to detect the virus better than an antigen test. There are certain situations, again, where the antigen test is useful, but for the most part, the PCR test is better. So for the antigen test, okay, someone goes to a clinic and they say, I want a rapid antigen test. Well, that typically has to be, in our understanding of the literature, needs to be a symptomatic person, particularly one with a COVID exposure. If you had a COVID exposure and you have a sore throat, a little bit of a cough, antigen test is the test that you could do quick. It's easier, it's cheaper, get it right on site. But it also can be used for surveillance. So if you're doing the test frequently, 2, 3, 4 times a week, you can pick up the virus right when there's enough for you to be infectious to other people. So it's also, antigen tests can be used in a surveillance strategy. Just getting it once and then a week later or 2 weeks later getting it again, that's not true surveillance, because once you get the test, the antigen test, you could turn positive in the next day or two. So you have to be really mindful that the antigen test might not tell you what you really want to know. The molecular test, or the PCR test, can be for symptomatic or asymptomatic people. And now we can use the PCR test to clear someone from quarantine. You get exposed, you should be in quarantine for 10 days. You can get this test and clear yourself within 7 days. So what used to be a 2-week quarantine can go down to a 1-week quarantine after exposure. It can also be used, obviously, to diagnose somebody and confirm a diagnosis. And there are a lot of people, we had one today, that need or want a PCR test prior to travel. They need something within 72 hours or 48 hours prior to travel, so they get a PCR. Also, let's say you're going to visit a vulnerable elder, you're going to get together with family. A rapid test, a rapid PCR test, a PCR test that's done that day and get results that day, can give you reassurance that you're unlikely to, if you have it, to expose other people, but it has to be that day. If you take a test and it's negative, you could be in a window period where if you test too soon, you could get sick. And that's what I want to talk about next. So it's kind of a lot going on this piece of paper. And I actually had to revise this because they changed the CDC recommendations the day after I created this infographic, which really disappointed me. But so let's say you're Jane, or Karen, that's your name. So she goes to lunch indoors with a neighbor, a friend. It's a couple hours, they're indoors, they have the masks off, they're eating. So you think, well, she's a friend, I know who's in her bubble, she's safe. But the next day she calls and says she felt sick and tested positive for COVID. So Jane's freaked out. She goes immediately to get tested, and she was told it's too soon. And that is true. The day after exposure, the day of exposure, the day you find out is just way too soon. So the symptoms can occur anywhere from 5 days up to 10, 14 days after exposure. That's why we haven't fixed it all the way. That's why it's currently recommended to do a 10-day quarantine after you've been exposed to somebody. So Jane, she gets just told to go away, but she says, okay, 4 days later, I want to go to a party, a cocktail party. I just want to get tested beforehand. So she goes and she knows it's going to take a few days to get the PCR back. So she goes to rapid antigen test, and she brings that to the party the next day. Well, as we just learned, rapid antigen test isn't good enough to detect somebody who's asymptomatic. So she goes to the party the next day. She says to her friend, here's my test. I was tested negative. And she proceeds to spread COVID-19 to 20 partygoers. So again, the rapid antigen test should not be used without symptoms. The next day, she kind of feels a minor sore throat. She's like, oh, it's nothing. She goes to the PTA meeting and exposes a few more people. Key point, if you feel sick, stay at home. If you feel sick, stay at home. If you feel sick, stay at home. And then the final day, she loses her sense of smell, and she goes to get then a rapid antigen test, and it's positive. Don't need a PCR test because the positive test is very specific. So at the onset of your symptoms, go get tested. You can get a rapid test. If that's negative, you'd probably need a PCR test to confirm it. So she was infectious for a couple days before she was finally diagnosed, and she ended up exposing a bunch of people. So get the right test at the right time. Don't get it too early because it can give you a false sense of security. And hopefully we can stop the spread. And I hope that helps, you understand kind of what tests are out there and what tests would be helpful for you. So this is what we have at Harper Health now. So we actually have both. We have antigen testing, which we have machines in both Hinsdale and Chicago. You do a curbside nasal sample, you do it yourself, it takes 15 minutes. We also have invested, and not many clinics do, but we invested in a PCR test, which is the same, this company is the same one that's used in a lot of hospitals. It's just instead of 2 active bays, they have 100. The machine's just a lot bigger than ours. But it's the same technology that hospitals are using to do the molecular PCR test. Same thing, curbside nasal sample. The test cycle takes 36 minutes. We can do 2 at a time. So there's sort of a limit in a given day of how many tests like that we can do. But letting you know that we have these resources and we can give a PCR test in a rapid way. It's not a rapid test like you'd think of, the rapid antigen test. It is a rapid PCR test, which is for our patients, a true, hopefully an asset, and that we have that available for you. Now because of our investment, there's a cost to each one of these tests. And if you go to schedule it, Priscilla will talk to you about that. But antigen tests, molecular tests, we have those available to help you as you navigate the next few months before you get your vaccine. Be safe. So we've got 2 sets of questions now. I don't know, Maggie, if you want to work from the bottom up to start with the ones on testing.
Well, pretty much everything is about the vaccine. One question about the testing is there a saliva screen? That YC.
Yeah, so we don't use the saliva test, but there is a saliva test out there. The University of Illinois developed a technology to use spit. There's also companies that you can send out. You can sort of send your, I think the U of I calls it drool. You can send your drool off to a company and they'll do it through saliva. And you'll see over the next few months, there's a company that's called Shield, Illinois, and they're using the technology that was developed at University of Illinois to spread that around the state of Illinois. So that you'll see that coming in the next couple of months.
Okay, so back to vaccination. Given the Pfizer vaccine needs to be stored at extreme cold temperature, do most medical offices, and yours in particular, have a way to store it?
I can take that. We don't have the super deep freezer, but that doesn't mean we can't get the vaccine. The vaccine is delivered on dry ice, and you have a day or 2 to administer it. And once it comes to room temperature, you have a couple of hours before it gets denatured. So that's for us and our panel of patients. This is not a problem. So, if we get the vaccine, we know time in advance. We just schedule people and we'll get it done. So let's hope we do get an opportunity to test our organizational skills.
There's a lot of questions that are kind of along the same vein, which is if you get vaccinated, do you still need to wear a mask, social distance, those kinds of things?
That's a great question. So there's a couple of things to think about within that. Do you need to wear a mask and social distance? The first is you aren't fully sure whether you're vaccinated, whether you are one of the 95% of people who are successfully vaccinated. There's currently no recommendation from the FDA to prove your immunity status by checking antibodies. We're not, we do our own thing. So I suspect, we'll talk as a team, but antibody tests are easy. It's just a blood test. And currently, your insurance companies are paying for it. So I think if you call us after getting the vaccine, we can check your antibodies and see whether you've developed some antibodies to the virus. The second piece with regard to that is if you don't know if you're vaccinated, you don't know if the person across the street or across the table from you has been successfully vaccinated. So for that reason, you might want to protect yourself just like you are today. The third reason to continue to wear masks is even if everybody's vaccinated, we don't yet know if the vaccine prevents asymptomatic but infectious particles from growing in your nose and potential for passing it on. So I believe that will come, not in 2 years, 5 years, so you're wearing masks forever and social distancing forever, but over the next few months, we'll learn that a little bit more. There's active ongoing studies from Pfizer, Moderna, and all of them about those specific questions. But our recommendation would be, even after the vaccine, still pretend like everybody has it, because you won't 100% know some of the answers to those questions.
Right. So we don't know if it produces a sterilizing type of antibody, which would prevent you from carrying it, even though it might not infect you. And then the other thing is we don't know how long immunity lasts. So even if you or someone that is in your family has been vaccinated, we don't know when that might wear off. So I think it's always important to be careful.
Let me add one more thing. All the stuff we're talking about is about risk. And if you're somebody who's willing to take risk and, you're okay with taking off the mask, I feel like, it's okay, I'm going to give this a shot. And, that's okay. We don't approve it. You're adults, you can make your choices, but understand that these are our recommendations. If you don't follow them, there's a risk to you. We're trying to mitigate that risk because, as I said way at the beginning, we don't want any of you to get COVID. So what our recommendations are really about doing everything you can to prevent you from getting COVID.
Are the Pfizer and Moderna vaccines identical? Or is there any technical difference between the two?
I suspect that there's a couple things that I don't know for sure, but I will tell you that they're likely different in subtle ways. The technology is the same, but they may have different lipid outer coats, that deliver the RNA. They may use a different segment of the RNA that codes the protein. But for all intents and purposes, they're basically the same vaccine. So there's obviously something different about it that requires Pfizer to be stored at -90 degrees, but the Moderna vaccine only at normal freezing temperatures.
What are the disease states that can make you high risk and go sooner? Is being a cancer survivor patient let you go earlier? A lot of people have asked about specific.
So, I'll chase Meg and I will chase this with a copy of the slides and to your email if you provided it with that question answered. I don't know exactly. There may be on that website the list of illnesses. We'll provide that for you if we can, and we'll get that out to you as soon as we can, because it's clearly a question that you're all wondering. Am I in the list of, if you're over 65, am I in the, sick category that enables me to get it sooner? So I'm sorry, I should have had that answer and I don't, and I apologize.
People are wondering about if they're on immunosuppressive therapy, how that would affect the vaccination.
That also is a very good question. We do recommend people who are even on immune suppressive therapy to get most vaccines. There are some live vaccines like the measles vaccine that has live virus in it. We don't recommend that for people who are immune suppressed, but we do recommend it will possibly blunt your response to the vaccine, but we recommend that you get it, just like we recommend you get the flu shot. So immune suppressives may blunt your response, but we are going to recommend that you get it.
If you've already had the virus, can you still get the vaccine?
It's recommended you get it because I think it's 3 weeks after infection. There's a number for how soon after you're infected that you can get the vaccine. But the FDA recommends, even if you've had COVID, get the vaccine because we don't know, again, how long the immunity of getting infection lasts. So even if you've had it, get it. But ethically, I might back up a little bit and let some other people who haven't been sick get it. But again, that's a personal decision for you.
If you're a snowbird, can you get the vaccine when you're down in Florida?
Again, I didn't look up the requirements in Florida, whether you have to be a resident of Florida in order to get it, or just there in Florida. If you have to show your driver's license or proof of residency, I don't know. So I would just check with the particular the website of Florida and see what their recommendations are. Requirements.
A lot of questions about getting the vaccine in Florida. Apparently, there's going to be a mass migration.
Mass migration. You're going to get a rapid test at our office, and you're all going to get on a chartered plane and go down to Florida.
Yeah, and a lot of questions about side effects, which I think we have answered that the side effect profile is pretty mild. 2 people in Alaska, I guess today, had a severe allergic reaction, and they didn't have any known allergies. Will this force the vaccine to be given in a hospital setting only?
That is a great question. And again, this is the stuff that when you do it with 30 to 40,000 people, I might have to take back what I said. I'll put a disclaimer on the side effect slide. So this is stuff that happens, number one, when you expand anything from any drug, any medication, any device from a study to a larger population of people. And then secondly, it was only 30 to 40,000 people. So let's hope it's not the case. If that's the case, we might see more opportunity for the vaccine in our office. That might be a good outcome. So we'll keep an eye on it. Again, this presentation webinar is a moment in time, and hopefully, keep your eyes peeled and your ears open to further updates from us. So we have one more. Yeah, we got one more minute.
Somebody asked if, since the nasal swab testing is, if it's self-administered, is it possible to do it wrong?
That's actually
you shove it up there, good, and swirl it around. It's hard to mess up, I suppose.
Yeah, it is hard to mess up, and one could imagine if you have a child doing it, him or herself, they may not, fully get along the edge of the nose. So it's just unlikely that you're gonna make a mistake doing it, particularly if you have one of Harper Health staff instructing you. So,
what are the risks of getting the Pfizer vaccine if it's been at room temperature for too long? I think the RNA just denatures, right, and it doesn't work. There
won't be a risk, but
the risk is it not working.
Yeah, you won't be properly vaccinated. So that's the important key point about this whole supply chain thing. And I suspect that Pfizer, a little bit of a cynic here, but Pfizer is creating this infrastructure around the country for these deep freeze vaccines, not just for the SARS-CoV-2 vaccine, but other vaccines that they can develop in the future that require deep freezing. So we'll see how this plays out over the next 5 to 10 years, but don't be surprised if you see quite a few Pfizer vaccines coming down the pipeline that require deep freezing.
The last question, I think, is asking about sorry, more questions keep in it, about university students. Will they be able to get vaccinated at school or at home? I don't think we know
Yeah.
anything about that yet. If a husband is 65 and the wife is 61, is it possible for them both to get vaccinated? I think it's going to be an individual. You know, I would
Yeah.
love for everybody to get the vaccine, but we have to look at each person individually, I think.
Yeah. If it comes to us, we're going to do our best to follow protocols. But, you know, if we get a 500 vaccine supply and 500 next in 3 weeks, you know, it's all patients, everybody will have an opportunity to get the vaccine. So at an individual practice level, you know, we will kind of follow the protocols. And my suspicion is, depending on the number that we get, we should be able to accommodate our patient panel based on our small number. All right, well, we are over time. You know, we are at 5:32, and, you know, I appreciate the questions. It's, you know, you're engaged, and I'm sorry we don't have all the answers. This was to try and update you, and unfortunately you came with questions and we couldn't answer them. So when we hear them, when we get answers, we will pass them on to you. And the primary way that we pass it on is through our newsletter. It gets sent out, you know, once, twice a month. At the beginning, it was sent out 3 times a week. So if you're not signed up for that newsletter, but also check your spam. Sometimes it gets pushed into spam. And, you know, if you're not signed up, just email us, let us know, and we'll get you an invite to the newsletter. So again, thank you. Please stay safe, and happy holidays to everyone. It's a special time of year. It's going to be a little different this year, but just for 2020, 2021 is going to be a big party time. So looking forward to partying with you all at some point. So take care. And if you have any further questions, just pass them on by email to one of us.